All right, so today we're going to talk about code groups for claim processing. We're also going to talk about the prior authorization process for OHP fee-for-service members. And I'm just going to go around the room real quick and have us introduce ourselves. I'm Jennifer Smith. I'm the Medicaid program trainer.
I'm Nathan Roberts. I'm a policy analyst with Medical Surgical Programs.
Colette Gillies, provider campaign coordinator with the Community Partner Outreach Program.
And I am Trevor Douglas. I am the provider clinical support unit manager.
All right, so we have plenty of experts in the room to answer your questions if you have them. Let's go ahead and get started with claim groups for claim processing after we go over the agenda, of course. Discussion points for today, we're going to have a brief introduction about the code groups. We'll talk about procedure code groups and diagnosis code groups. And then we're going to talk about the PA process for fee-for-service members. We're going to talk about how to know which services require prior authorization. We'll talk about the process on the MMIS provider web portal and also the paper process. And then at the end of the slideshow, we'll have some resources and contacts for you. So here's an introduction to the code groups for claim processing. There are services that are included in the minimum benefit. So those are code pairings that are above the funding line on the prioritized list. But there are some codes that are not on the prioritized list, and that's what we're going to talk about with these code groups. We have some diagnostic services and also ancillary to covered services. Also, there are services that are not included in the minimum benefit. So any code pairings that are below the funding line on the prioritized list, we have excluded services that are not on the list. And we'll talk about each of those code groups and where you can find them on our website. A little too far. All right, so it's the fee-for-service code management strategy. We'll talk about payment and adjudication. So fee-for-service and CCOs need to have a pathway to access for all covered services as long as they are medically appropriate. Fee-for-service has a near one-to-one relationship between covered codes and payable codes. And there are some exceptions to that, and that they include bundled codes or multiple code options for the same service. And then when it comes to adjudication or claims adjudication, prioritized list codes are loaded into the MMIS, and then the non-prioritized list codes are grouped in MMIS, and there are restrictions set up where your claims will hit up against those code groups that are set up in MMIS. And just so you know, we're not going to talk about the prioritized list codes. There's an assumption here as we talk about the code groups for claims processing that you're already familiar with the prioritized list. If you're not, if you have questions about that, we do have a resource that at the end of the slideshow that we'll talk about for you to contact with help for that. We also have lots of training videos and information on our website if you need to know more about the prioritized list. So fee-for-service changes that happened on in October of 2015. New codes for all the ICD-10 diagnostic code groups. And fee-for-service was we reorganized the diagnostic code groups to add clarity. And just a little note here at the bottom in that box emphasized there. Because of the changes, there are errors in some of the groups, and they don't negate our obligation to follow Oregon administrative rules regarding covered services. So there may be some errors that would they bring them to our attention? Is that okay? Just want to clarify a little bit on that.
Yeah, so bringing them to our attention should go through the provider service groups for fee-for-service, and then if it's a CCO claim, through the CCO to the account reps and to policy.
Okay.
Kind of the pathway.
And there's a lot of work going on internally as well in making sure that those code groups are accurate. So please do know that there's a lot going on internally, but if you come across something, we would really like to know about it. So Medical Surgical Services Program, there's the website directly to that program page where you'll find the Oregon administrative rules, you'll find supplemental information, and down in the supplemental information you'll find the code groups for claim processing. And there are several code groups that you'll see. They're listed there. And you can click on each of the code groups and find codes that would be bundled or not covered. You can find the undefined diagnosis codes, and it will also tell you how those codes will or will not pay when you bring up those code lists. So you'll see undefined informational diagnosis codes, conditions not covered. There's a diagnostic workup file, diagnostic procedure codes, and then also the not covered, bundled, or not valid procedures. So again, if you have a code that you're not finding on the prioritized list, where you're looking and you're trying to find that pairing to see if something is going to pay, and you don't find that code on the list, then you would want to refer to these code groups and find out how that code works with our claim processing. And also there's an additional procedure group that's not yet published, and that's the ancillary procedure code group. All right, so I'll give you a little bit of information here for procedure code groups and what you'll find on the website when you go and click on those groups. So the not covered, bundled, and not valid procedure code group, it's part of Oregon Administrative Rule that's listed there. And I'm not sure, is the Excel version already?
No.
It's not. It's still not up. Okay, very good. Just wanted to make sure. And then there's also a table in the Oregon Administrative Rule where you will find those procedure codes. So there's 3 indicators as you look at that code group or that table. N means that it's a non-covered service. B means that it's bundled. And NV means that it's not valid. So another coding option would be used for that service. Do you want to add anything to that, Nathan?
Only that you'll find some of the Bs and NVs on the prioritized list, maybe even above the funding line, because they are covered services. And what that means is that our pathway to payment for those covered services is either that it's bundled under a payment for another code, or we're directing you to use a different code. There should be a different coding option that you can use to bill for the same service.
Great, thank you. Okay, then we have our diagnostic procedures. Most of these are not included on the prioritized list, and they're covered by the fee-for-service program when they're billed with a diagnosis code from the diagnostic workup file. So sometimes you're going to be using more than one code group to kind of find that match that you need to have that pathway to payment. And whether the diagnosis code on that workup file is above or below the funding line, these should be paying with a diagnosis code from that. Yes.
Bit? So the procedure code, diagnostic procedure codes, which are mostly labs and imaging and other office visits for diagnostic purposes, they will pay paired with a code in the diagnostic workup file, which are diagnosis condition codes that are not on the prioritized list, and they will also pay with any diagnosis code that is on the prioritized list, either above or below the funding line. So we are paying for diagnostic workup to rule in, rule out anything above or below the funding line, and also the diagnostic workup file is where we put conditions that are really not very well defined. So the code for nausea, one of the R codes that's just for nausea, we don't really know what's going on with this person, but they have this nausea that we need to investigate. You can bill the labs and office visits and imaging kinds of procedures if they're needed because it's in the diagnostic workup file.
All right, thanks, Susan. All right, we have ancillary procedures. This one is the one that's currently unpublished, but this is anything in support of a covered service. So for example, there we have anesthesia. And this would be covered when the diagnosis is above the line. So our example there is a vaccine administration is above the line on the prioritized list, but the specific substance is not. And then we have our diagnosis code groups. We'll talk about each of those. Undefined diagnosis codes. These are not clear enough for claim processing, so we do need a more definitive diagnosis in order to pay for the service. Informational diagnosis codes. These are intended to just add extra information. They don't determine payment. So if these codes are used as a primary code, then the claim would be denied. So we have our example there. If we have a diagnosis for a contracted hand, additional codes stating why the hand is contracted, so family, personal history, that type of thing. These codes are just to add extra information to why the service was provided. They would not be able to be primary. And then we have our workup diagnosis codes. These are not specific enough to start treatment, but enough concern to begin diagnostic services. For example, chest pain, uncontrollable cough. They are linked with the diagnostic procedure list. So when the diagnosis is on the workup file and the procedure is on that diagnostic procedure list, then fee-for-service would pay. Also, when the diagnosis is on the workup file and the procedure is treatment-oriented, then fee-for-service would deny, because we would expect a more specific diagnosis. And these conditions about when they would pay or which code group they would pay with, those types of things are listed in the actual file that you'll pull up from the website. So if you were to pull up, let me just go back to this slide. So if you were to pull up the diagnostic procedure list and the workup diagnosis list together, each of those would say basically the information that we're telling you here, when it would pay for fee-for-service, as long as it was with a diagnostic procedure. And then we have conditions that are not covered. These are just diagnosis codes that are never paid on a fee-for-service basis. So that list is also available to you. All right, and we're going to start with the prior authorization in just a moment. I do want to see what kinds of questions we have coming in real quick. Is there some other, okay, so that has to do. Okay. So we have someone that maybe hasn't been able to call in. You could listen on your computer with your speakers. Let me find you in our list really quick. I'll ask the following questions and see what I can do for you. When is the ancillary code group going to be available?
It is on my short list of priorities, and I'm working on it as fast as I can, but I can't give you a date. You know, we're in the middle of session, and I am pretty swamped right now. So I'm committed to getting it done, but I really can't say how soon I'll be able to do it.
Okay. Thanks, Nathan. What is a diagnostic workup file? So that's just the code group, the name of the code group that is listed. So you would be able to pull up that diagnostic workup file on our website. Go ahead, Nathan.
Yeah, sure. So as a principle of what's covered for OHP, we cover diagnostic procedures, and there are some codes that are important, like the uncontrolled cough or the nausea, important for diagnostic work, but not specific enough to be ready for treatment. And so we put them in this code group that we're calling diagnostic workup file, and we make them available for diagnostic kinds of services, but limited, so that you know, if someone has a diagnosis of chest pain not otherwise specified, we aren't going to approve procedures like heart surgery, but we are going to approve procedures for imaging or other kind of diagnostic work to find out what is going on. So that's what is in that diagnostic workup file code group. It's ICD-10 diagnosis codes that are needed for diagnostic work, but not specific enough for us to start paying for treatment.
Okay, and one more question before we move on to prior authorization. By undefined diagnosis, does that mean any description that contains unspecified or other as part of the description?
You'll see a lot of them that say those terms, but that isn't how we determined that group. We did look at them case by case, and in some cases we did find that codes that have unspecified or other in their definition were still appropriate for either diagnostic kinds of work or in some cases treatment. So no, it's not 100% match on that.
All right, so prior authorization, we're going to talk about the process for fee-for-service members. Again, we'll talk about services that require prior authorization. We'll talk about the process on the provider web portal and also the pay-for process. So services that require prior authorization, you'll find in our general rules, the rule is listed there, that some services require prior authorization. But this rule also refers to other health systems division rules for which services require prior authorization and the PA process under those other rules. This rule also requires appropriate documentation to be submitted with each PA request. It advises when authorized services will not be paid, and it also talks about how to request retroactive authorization if that's something that you need to do. You would also refer to other HSD rules, just like it tells you in the general rules, and the prioritized list to determine which services require prior authorization. So for example, if you are a durable medical equipment provider, you would look directly at the DME rules, and it would talk about specific services that do require prior authorization. So it's very clear in each of the rules which services do and which services do not. Also, when you look at the prioritized list function on the provider web portal, it should also be telling you if prior authorization is required. And then we also have a team of people that can help you with the prioritized list and a team of people that can help you with prior authorization. So filling out and submitting a new prior authorization on the provider web portal, you would first of all make sure that you are logged into the correct provider ID. And then under prior authorization, you would click on New. It would take you to this screen. This is the first of 3 screens that you need to fill out in order to submit a prior authorization. You'll see required items listed on the right and numbered, and also what steps you would take. So your first step would be to enter the client ID. As soon as you enter the client ID, when you click in the next field or somewhere in the blue area, that person's name and date of birth should automatically populate. If they don't, then you might want to use the search button next to the client ID because the client ID is not correct. We also do need a PA assignment, so that'll be a drop-down list for you there to choose a PA assignment. Special considerations and attachments are automatically set to no. If you do have attachments, you want to change that to yes. Special considerations, it's not something that's used very often, but if you had some special consideration where you were asking for prior authorization for something that's not typical, then you might change that to yes and include that in the notes that you send across with the PA. Your next step would be to click on Add. That's number 3 on the list. If you don't click on Add, this section just isn't available. You'll try to click on the fields and they won't populate at all. So make sure you click on Add before you enter a diagnosis code, not after. If you enter a diagnosis code and then click on Add again, it's going to expect you to enter a second diagnosis code, which is fine if you have a second diagnosis code. But if you don't, what will happen is you'll get through the process and the PA will not allow you to submit because there's an empty line sitting there. So add before, not after. Then you would enter your diagnosis code in the diagnosis code field. That's number 4. And then your last step on this page would be to click Next. Next takes you to the second screen of 3 that you need to fill out. And this is really the detailed information about the prior authorization. It's called the line item. Your first step would be to choose a code type. So that's the drop-down menu. It includes procedure code, revenue code. I believe it includes NDC. And then based upon your decision, whichever code type that you choose there, then your fields kind of change a little bit. So if you click on the next field or in the blue, again, the screen will update. Your second step is to enter information. So you'll enter whichever code, procedure, revenue, or NDC, based upon your service type code. You do need to enter the service provider ID, the requested effective and end date, and the requested units. Your third step, if needed, you would click Add to enter additional line items. Again, the Add button is something that you use before entering information, not after. If I were to click Add, but I only had the one line item, what's going to happen is it's going to give me a second line item that if you need it, great, use it. If you don't, then you've clicked Add and you have an empty line item, and your prior authorization will not submit because of that empty line item. So use it if you need it, add before, never after, and then you click Next to continue, and you'll see there's also a previous button. So if you needed to go back to the previous page and add something or change something, you could do that here. Our third and final page for the provider web portal is the notes page. Notes are optional, but again, I would say that if you have any special considerations, if you have any attachments, please use the notes. You may also, other things that you might want to put here is maybe you work for a large organization and you're entering this prior authorization and you want to be the contact for this prior authorization. That might be good information to enter here. But please do use it for any special considerations or explanation of attachments. So to use the notes section, you have to click Add. It's not available until you click Add. And then once you type your notes in, you can click on Save, and that submits the prior authorization. Once you've clicked on Save, you'll get this message up here. Hopefully it tells you that the save was successful. Your prior authorization number is included there. You can check status on the authorization using that number. You do want to take note of that number. And then if you have any supporting documentation, you'll see the cover sheet button down on the bottom right. Once you've submitted your prior authorization, or if you've submitted a prior authorization, you closed out of the provider web portal, you come back later, you open it, you can find this cover sheet button. Any of your supporting documentation needs to be faxed to us, and that cover sheet is the cover sheet that we require you to use. It allows our system to scan things in and make sure that they are attached to this prior authorization. So it's called the EDMS cover sheet. Go ahead, Trevor.
It's important to also remember that that cover sheet must be the first sheet in the fax transmission. So don't use your own cover sheet and then put this cover sheet. It needs to be the cover sheet of everything that you wish to send in to us.
Right. Our system uses that cover sheet. There's I don't know, some sort of specifications on that cover sheet that tell our system this is something new, and it separates documentation. So if your cover sheet is in front of this cover sheet, it goes somewhere else. It doesn't get connected to this prior authorization. So yeah, it should be the first sheet that you use. And again, you can access it right here, right after you've clicked on Save, or if you needed to close down for some reason and go handle something else, or if you got timed out of the system, you can come back to this prior authorization and look at it and see that cover sheet, and it will populate for you again if you click on it when you do a prior authorization search, which we'll talk about next. Okay, so to search for existing prior authorizations, again, you do want to make sure you're logged in as under the correct provider ID or Medicaid ID. You would click search under the prior authorization menu. And then what happens here is when you click search, your 10 most recent prior authorizations will show up in a list. So if it's one of those that you're looking for, great, you can just click on it. It'll take you directly to that PA. If the one you need to look at is not in this list, maybe you're checking status or you want to look back on something to see if you have additional units to bill, then you can use the search screen on the bottom. You can use the prior authorization number, any of the specific criteria that's listed there you can use. And then you would click on the search. Now what happens when you click on search, if there's only one prior authorization found, maybe you put in the prior authorization number and it only found one, then it's just going to bring up that prior authorization. If in your search there's more than one prior authorization that matches the information that you searched for, then you'll get search results at the bottom of the screen in a list format. But you'll notice that your list of your most recent prior authorizations is still there. And all you need to do, whichever list you use, you would just click on a line item to open that PA and view it in the system. This is the prior authorization view once you have it in the system. And you'll notice it looks just like the screens you filled out. You'll also have the notes page at the bottom there. But the base information here all the way through the diagnosis, that was the screen 1 that you filled out for PA. And then you have your line item, which was screen 2. And then the third screen was a notes page. And when you look at the full view, you'll see at the very bottom below the notes page that that cover sheet is available again. So the information that you see here, I want to talk to you specifically about the status codes. So the status codes that you'll see on the line item, I just want to tell you what those mean. Evaluation, it means that the PA has not even been reviewed yet. So if you see evaluation, it's sitting there, it's in our queue, and we just haven't looked at it yet. If it's pending, it's in the review process. That means someone is looking at it and a decision will be made hopefully in the near future. Approved is pretty self-explanatory. Denied as well. Now if you do have an approved PA, you want to make sure that you look at the approved effective and end dates, like the authorized effective and end dates and units and dollars. So when it's approved, you'll see that information right below where you had your requested units here and dates, and then you'll see authorized units here. And then if you see a status code of informational, that just means that no PA was required for this service. And then a withdrawn status means that there's a duplicate PA on file. So you would want to search using more general criteria if you use the PA number specifically, maybe search by client ID and dates, and you'll see that duplicate in there. All right, so let's move on to the paper request. So the prior authorization request form is 3 pages also. And I just want to stress again that regardless of how you're sending your prior authorization, that we do need the EDMS cover sheet. So if you're using this paper form for your prior authorizations instead of using the provider web portal, this needs to come to us with an EDMS cover sheet in front of it. That needs to be the very first page. All right, so page 1 of 3, and what I've done is over in this box on the left-hand side, I've told you exactly what's required. That doesn't mean that you don't want to fill out some of the other boxes. It just depends on the situation, but the prior authorization will not even be processed without this information. So in box 1, our requirement is that we have your provider number. Can that be Medicaid number, NPI, either?
Yeah, you can put either of those numbers. The Medicaid number is preferable. But.
Yeah, the Medicaid number is always preferable, even when you're using the provider web portal and putting in service providers or referring providers, because sometimes your NPI is shared across different Medicaid IDs, and we don't want the system to pull the wrong Medicaid ID. All right, in box 2, you do want to let us know what type of PA request this is. In box 3, we definitely need the client ID or Medicaid ID of the member. That's the same thing, client ID, Medicaid ID, member ID. If you hear any of those terms, they're the same thing. I think some people even say recipient, so all the same thing. Box 4, we do need revenue codes if those are applicable to your prior authorization. And then I do want to point out at the bottom of the page, if you're a pharmacy provider, there's a totally different form. This is for medical providers, and I've included a link at the bottom of the page here to the pharmacy form. All right, on to page 2 of 3. And again, the required information, there's 2 of the boxes there that I've kind of put aside, where boxes 6 and 8, this information is just situational. So dental providers would use box 6. And then if there's performing provider information where maybe the referring provider is submitting the prior authorization and the performing provider is a different provider, then that information would need to be included in box 8. So other than those 2, the required information, the minimal information that must be on every prior authorization for processing purposes. In box 5, you would put procedure codes, if applicable, and units as well. In box 7, the NDC code, if there's an NDC code being used. And then box 9, we definitely need the date of request and the expected begin and end dates for the PA. And it's very similar to the provider web portal, actually, the information that you're entering. So page 3 is a notes page and attachments. So notes are any written justification or other helpful notes. And you would refer to your provider guidelines for requirements on what you might need to include here. Attachments, we just need a description of the attachments. Again, refer to your provider guidelines for what might be required here. A document control number is not required. Report type is not required. Just if you have attachments, you do want to let us know what those are. And then I'm just going to say one more time. Make sure that the EDMS cover sheet is the very first sheet that comes in front of each prior authorization request. So you also wouldn't want to, let's say you're just filling out prior authorizations and you've got 5 of them. Great. You need 5 EDMS cover sheets. And they need to go in front of the first page of each prior authorization. And then you could include any attachments after that. Now, Trevor, I just want to clarify. So I've got my 3-page PA request, and I've got my EDMS cover sheet, and I have attachments. Would I just tack those onto the end just with the same EDMS cover sheet?
Correct.
Okay.
So on your anything that you send in for documentation purposes for a specific PA, that PA number, whether you created it yourself on the web or whether it's the first one on this paper submission or subsequent ones once that you've actually submitted your initial and they're asked for additional information, you'll be given that PA number. Use that PA number on the cover sheet if it's a subsequent transmission. The initial one, you'll be assigned a PA number if it's, you're just starting everything by the PA process on paper.
Right, so when you're initially sending over a paper PA request, you won't have the PA number. But a PA number is created as soon as it's in our system, and any subsequent information, you will need an EDMS cover sheet with that PA number on it. That's how our system ties whatever you're sending to us to that PA in the system. And here it is, the EDMS cover sheet. So not all of that is required. Again, if you look to the left, we do need to know the document type that you're sending. So you would want to X the box that says prior authorization. And then if you do not mark one of the processing options here, so we have routine, urgent, and immediate, if you don't mark one, then your PA is automatically going to be routinely processed. If you do have an urgent or immediate request, you would want to check those boxes and then give justification, an explanation here, and also your documentation should justify that. And documentation identification numbers, so we do need the provider ID and the recipient client member ID. That's all the same thing there. And then if you do have the prior authorization number, you do want to enter it in the prior authorization number boxes right down here for any subsequent faxes that tie to that PA. Anything to add?
I would just say that if you wanted to make it easier for our staff to help you, the top of that sheet allows you to put a from person and a phone number. So if you're a large entity that you wish to be that go-to person for this particular prior authorization or the request for this specific member, putting that information there is going to be very helpful. This will be the first thing that my staff, my reviewers, look at. And if they have questions, it'll make it very quick for them to be able to call the right person to get answers to questions they might have.
All right. Okay, so I'm going to give you some resources and contacts, and then we'll open it up for some questions. So OHP policies, rules, and guidelines, you'll find all of the policies listed on that page. Our medical surgical services program, that's the page specifically to that program. How to use the provider web portal, there are all kinds of resources, step-by-step guides, handbooks on how to use the provider web portal for prior authorization and for other functions. And then out-of-hospital births. There are 2 OHP announcements that talked about prior authorization for planned out-of-hospital births, and those have been required to have prior authorization since December 1st of 2015. So if you need more information on that, there's 2 resources for you there. We also have some groups available to help you if you need help. We have the code pairing and prioritized list helpline. We have the prior authorization help, and we also have our provider services unit. So you can contact any of them at any time if you need help with specific information. Our provider services unit can help you with claims resolution and policy interpretation as well. So you'd want to contact them. All right, so let's go ahead and take some questions. First question, how do I get access to the HSC on the web portal? So this is something that you will find on your menu, just like we looked at the prior authorization menu and we saw new and search. Under the providers menu, you'll see benefits and HSC inquiry, and that will take you to where you can enter specific diagnosis, procedure codes, dates, and look at information from the prioritized list based upon those codes that you're entering and that date of service. If you don't have access under your login, you would want to contact the administrator at your site to get that access. If you don't know who the administrator at your site is, then you would contact Provider Services Unit.
So I have another point to just help out in that regard. If you have questions about the current and past prioritized list of services, you can Google very easily just what I said, OHP prioritized list of services, and it'll bring up the current web page. And you can actually, there's a number of resources, including a searchable list, which is quite handy and quite helpful. There's also a number of PDFs there that help point to specific lines and help you as a person trying to navigate the prioritized list for your organization find the right and appropriate coding solution in order to help you navigate the claims process for your entity.
Can I also add one piece? If you are using the MMIS HSC lookup tool, it includes the logic from the code groups that we talked about earlier. So if a code is not on the prioritized list, you might get a message like, this code is diagnostic and covered, because it's also looking at those code groups that we talked about earlier.
All right, next question. We have had trouble before with attaching documents and have been told that once it's submitted, we cannot go back and add documents through MMIS. We have to fax them in instead. Is this the best way to do this? So yes, even if you're using the EDMS cover sheet from the provider web portal, there's not an attachment option. You can't attach the documents right there on the provider web portal, so you have to fax them anyway. So it's just, excuse me, a matter of getting to the EDMS cover sheet and making sure that you use that cover sheet for supporting documentation. So the provider web portal is only providing you a button that you can click on to get to that EDMS cover sheet. So you can either go back in the provider web portal and pull up that cover sheet, or you could go to our website and on our forms page search for 3970, and that's going to give you that EDMS cover sheet. You can also find it on our Tools for Providers page, where there's a list of documents and forms available for you. Will the cover sheet work in an electronic fax world after being scanned, a main page, as a main page? I'm not sure. I would say try it and let's see how it works out, and then we'll know. I imagine that it would. There's a lot of electronic faxing going on. But the reason, part of the reason that the EDMS cover sheet is so important is its format. So if you were to fax or to scan it in as a document, you would just want to make sure that it's exact, because our systems that are scanning documents in are recognizing that format to separate documentation from each other. That's why you need one for each set of documentation that you're sending over. What is KeyPro's role in the PA process?
So that's a great question. So KeyPro is a contractor that has been with us since 2009, I believe. And recently they have been helping us with the behavioral health and mental health residential system, and have been doing quite a great deal of work with regards to those types of services. They have just recently also begun assisting us with some of the physical health prior authorizations as well. But their reach is rather limited at this point with respect to those services.
All right, next question. How do you get an EDMS cover sheet when completing the paper prior authorization? So let me get back to that really quick. All right, so if you look at this page here, this is the EDMS cover sheet. And this is the name of the cover sheet on our website, MSC 3970. If you go to the Oregon Health Plan webpage, you can just Google Oregon Health Plan. It's going to take you right to that page. On the left-hand side, there's a menu of options. And there's a section specifically for providers. Under that section, you'll find two different links that would help you get to this form. One of them is Tools for Providers. When you click on Tools for Providers, there's a web page that comes up. And if you scroll down that web page, you should see Common Forms. and you'll be able to find the EDMS cover sheet there. You'll also be able to find the prior authorization form there. Another option under that providers section menu is forms, and that'll take you to our forms page where you can just type in this number 3970 and find the EDMS cover sheet. Now, if you want to if you wanted to find the prior authorization form, you would type in 3971, and it would take you to the prior authorization form. Is the PAN, prior authorization number, the same number, the same as an approval number? So no, the prior authorization number is a number that's assigned upon submission. It does not mean that it's approved, but the prior authorization carries that number through the process. So whether, again, it's assigned upon submission so that you can track the authorization request. If that request is then approved later, it doesn't get a new number, it's the same number. So it's throughout the process. But it's not just assigned to approved PAs. When requesting prior authorization for services that have varying levels of complexity, i.e. physician visits, therapist evaluations, can we use the highest level CPT code and assume all lesser codes will be approved? Or do we need to submit each individual CPT code? Leveling or complexity is not determined until the provider has completed their visit. You want to take that? We need each code, right?
Yeah. So I can answer that. So all codes that are subject to prior authorization will need to be included on the request. And so when you're submitting your prior authorization on the second page of that request, there's a column that has room for ample number of codes. If you need more, there's a note section. You can put them all there. In box 4, I believe it is, there's also a diagnosis code thing. You could put your diagnosis that you have as your working diagnosis, and in the notes section you could probably make a reference to the multiple other diagnoses that may be referenced in the medical documentation that you're going to attach later. So as long as the information that you are providing on that second page includes all of the services, the CPT codes that you wish to have authorized, provided they require prior authorization, as long as they're all there, then we will evaluate it and provide you with an appropriate approval or denial or informational status, whatever the case may be.
Thanks, Trevor. Next question. What happens? Is it kind of the same thing? Let me read through it real quick.
No, it's just maintenance.
Huh?
It's maintenance.
Okay. So what happens when a diagnostic test like lab or imaging supports a different diagnosis than what was on the prior authorization? We make an order from a referring physician with a prior authorization for a suspected or expected diagnosis, but the results of the diagnostic testing may not support the exact diagnosis. We can't change the findings of the testing, so how do we receive payment if we can't guarantee the same diagnosis from the prior authorization will be supported?
This is a complicated one. So it's provided provided the provider that is faced with this situation takes every effort they can to mitigate things on the front side would be helpful. So one of the things that Jennifer shared earlier was the code pairing and prioritized list line. If you have questions about whether something's covered or whether something is diagnostic, those folks on that line are all clinical folks. They should be able to help you and determine right then and there what it is. Now, if this is an emergency type situation, none of this applies. It's you know, you need to take care of the emergency, take care of the emergency. But this particular question seems to be based upon whether or not it's diagnostic or not. So just need to make sure that the coding you're using appropriately reflects the fact that you are in a diagnostic frame of mind, and that the codes you're using are indeed part of that diagnostic. Get something else in?
So some diagnostic procedures require prior auth, like MRIs. I'm wondering if they're asking about that situations.
So yeah, so as long as, again, if you call the code pairing and prioritized list helpline, they should be able to provide you with ample information around which of those services, such as MRI, that require prior authorization, what guideline notes you need to meet that are part of the prioritized list. Guideline note D4 and D11, I think, are probably the most commonly used ones, which are C-spine and lumbar spine MRI. And if there's any other guidelines that are relevant, they can help you navigate what those, point you to where they are and help you navigate through them.
Okay, next question. In the past, we were able to submit additions to previously approved authorizations when we ran out of units. KEPRO recently informed me that they no longer can do that and that we should contact OHP, I imagine the state. Who should we contact?
All right. So this is probably coming from someone from the behavioral health world, this question. Prior authorizations mean exactly that. We are going to prior authorize services. The mere fact that you are running out of units would imply that you probably need to submit a new prior authorization to ensure that those services are prior authorized. So I hope that answers the question.
Also, how about PAs that are more than 30 days?
So again, I'll address this. The term PA means prior authorized. So 30 days past is not prior.
All right, next question. Is KEPRO inputting PA requests into MMIS for approval, or should counties be doing this? So this is another behavioral health.
Yes. No, KEPRO will be doing, KEPRO and OHA both enter in PA requests into MMIS. But
now,
this would be, there's a specific difference. So like if it's a behavioral health, mental health, there is a process in place for KEPRO to help with that body of work. With some of the physical health world, KEPRO is helping with some of that work, but the lion's share of it remains with OHA staff.
So I want to clarify.
Yes.
KEPRO does enter authorization requests on the behavioral health side. Do they actually enter requests anywhere on the medical side, or is that the that's the provider responsibility, right?
I misspoke. So KEPRO does. When you say inputting PA requests, my mind went to responses to said requests.
Right.
All right. So to clarify, KEPRO does not enter in the PA request.
Right.
The provider providing the service needs to be the one submitting the request to KEPRO or behavioral and mental health services. There's plenty of help with respect to how to navigate the behavioral health prior authorization process on KEPRO's website, which is www.ohpcc.org, I believe. Look.
Well, I'll send that out to everyone.
Yeah.
We'll verify that address.
And anyways, on that, there's a provider tab. You can click on that, and you'll be able to be connected with appropriate phone numbers. You'll be able to connect with the forms that are required to submit those requests.
Right. So, yes, it is the provider responsibility to submit the request. I do want to say, regarding behavioral health, much like the medical side where a referring provider might be entering that prior authorization request and they're putting the performing provider on that request, that's much like sometimes when the county, as the referring provider, might enter the authorization request and include the performing provider that they're making that referral to on that request as additional information of who would be providing that service. I hope that was clear. Please let me know if it wasn't. And KeyPro's website, I'll type it in as well and send it as a note, is www.ohpcc.org. Let me see. Next question, in what situations can we pursue a retro authorization? So that is something, I'm just going to refer you directly to the general rules, which I referenced earlier on, and take a look at the general rules because it talks very specifically about retroactive authorization and when you can submit for that. I remember, I can't recall every situation, but I know that one would be if you had someone come in and they did not tell you that they had OHP and you began services where maybe their primary, maybe OHP is secondary, but maybe their primary insurance doesn't require prior authorization, so you just moved forward with a service. So that might be a situation where you find out later they had OHP and you need to submit a retroactive authorization. All right, I am sending right now to the group that's here attending with us today, so people who are watching the video later will not get this, the KeyPro web address, which again is www.ohpcc.org. Next question, is the eDMS cover sheet required for emailed PA requests? So again, that's on the behavioral health side, and I think that behavioral health is a little bit different if they have allowed email PA requests. As far as I know, we don't allow email PA requests. We allow either the provider web portal or we allow paper requests. The paper request definitely needs an eDMS cover sheet. The provider web portal request needs an eDMS cover sheet for supporting documentation and attachments. So maybe let's take that one offline if maybe you want to get in touch with KeyPro directly and talk to them about this email question. Next question, can Medicaid recipients choose to pay out of pocket for services that do not meet prior authorization guidelines, medical necessity, or as a Medicaid provider should we refuse to provide the service? So with this, I'm going to point to the general rules again. We have very specific rules about when a provider can charge a member of OHP. So we're considered the payer of last resort, and we are considered payments in full. So there are some situations where a member may decide to pay out of pocket for a service, but it's very specific, the guidelines are very specific, and you would want to look at the OHP general rules and the client agreement to pay. We have a very specific form around that, and it also tells you the requirements of when you would want to use that form. If at any time a provider is going to bill a client for anything, there must be an agreement. That specific agreement must be on file, filled out by both the client and the provider prior to the service. It must be very clear in that client agreement to pay how much that service is going to cost them, and that must be consistent through the billing process. But also, there are very specific criteria. Sometimes we would allow providers, if they have that client agreement to pay on file, and the provider and the client both understand the situation and how much it's going to cost for a non-covered service, something that we wouldn't cover. But again, there are a couple of other situations where that might be allowed or appropriate. So please do look at the rules, because I don't have them all in file on my in my head. That's what I meant to say. Great question, though. All right, give me just a second.